We should start any minute now. We are waiting just for Professor Dr. Mujahid Masar and Dr. Ismail to attend. Okay.
So last minute then.
Yes.
Okay.
Please, Doctor, how I can pronounce your name? Just
Aysu.
so
Yes.
Babek.
Aysu iyi gün kabakçı.
If they are already So welcome everyone to the third session, the comprehensive neuroanatomy educational course presented by the Yemeni Neurosurgical Society in collaboration with the WFNS Young Neurosurgery Forum and Neurosurgery Coach and Pakistan Society of Neurosurgeons and the Neurosurgical TV. We are just waiting for Professor Dr. Mujahid Masar, head of Yemeni Medical Council and the president of the Yemeni Neurosurgical Society, to attend and to be moderator of this session, where today we have two distinguished speakers. First, we will have Dr. Aiso Kabaki that will talk about the anatomy of the parietal lobe, sulci gyri, and functional areas. And then we will have Dr. Ismail Mansour who will talk about the embryological development of the brain. So let's see if Dr. Mujahid ready in or no. Dr. Aiso, I think you are considered neurosurgeon at Republic of Turkey Ministry of Health.
Yes, you're
Department of
right.
Neurosurgery. Yes.
Yes.
Yes. That's good. You do all surgeries at your hospital, or you just certain operations or certain branch of
Almost
neurosurgery?
all, actually. Almost all, yes. We just haven't
But you are specialized
epilepsy surgery.
elective
sorry?
surgeries only. Are you specialized in what branch of neurosurgery?
I'm actually interested in neuro-oncology and also the endoscopic approaches to the skull base, but we perform all kind of surgeries. I'm just one of the young neurosurgeons, so I'm not specialized. That's
good. We are waiting for Dr. Mujahid.
يا دكتور أحمد.
دكتور مجاهد، كيف حالك يا بروف؟
كيف الحال؟ جمعة مباركة.
الجميع إن شاء الله. كيف يا بروف؟
الحمد لله.
Shall
we start?
دكتور
أيسو.
يمكن بس تقدم تعمل ويلكم سريع وتقدم الدكتورة ايسو كباكي تقدم محاضرة حقها وبعدين نبدأ.
You
تمام.
are welcome, Dr. Ayusi Kabaki.
Thank you.
And we can start.
All
with
right.
great thanks.
Thank
For
you.
the
I'm
parietal
sorry.
lobe, sulci and gyri and functional areas.
So good
Thank
evening.
you, Doctor. You can start.
Thank you. Good evening again. First and foremost, I'd like to extend my sincere gratitude to the Yemen Neurosurgical Society and Neurosurgical TV for giving me this opportunity. And today I'm going to talk some about the parietal lobe. So I will sequentially discuss the boundaries, sulci, gyri of parietal lobe for both lateral and medial surface of the parietal lobe. And I will summarize the functional areas within the parietal lobe, and lastly and briefly, I mention the blood supply of the parietal lobe. If you look at the etymology, in Latin, paries means wall, so the parietal bones constitute the wall of the brain. Like the other lobes, the parietal lobe is named after the bone that covers it. And firstly, I'd like to mention the Professor Yaşargil's surgical concept, and there are 7 lobes according to Professor Yaşargil. And here we see that postcentral gyrus is a part of central lobe and not involved in parietal lobe according to this concept. So on the lateral surface, the parietal lobe only have the superior and inferior parietal lobule. However, in the remaining slides, I'm going to accept postcentral gyrus as a component of the parietal lobe for better orientation. So the parietal lobe will be comprised of the postcentral gyrus, superior parietal lobule, inferior parietal lobule, and the precuneus medially. Indeed, the anatomy of parietal lobe is much more complex than this, so I want to tell more about boundaries of parietal lobe by using one of our laboratory's 3D model. This is from Yeditepe University Microneurosurgery Laboratory, and you can reach this model by scanning this QR code. So first of all, we have the central sulcus as an anterior boundary of the parietal lobe. Then we'll have the postcentral gyrus just posterior to it. And then we have a very prominent sulcus located here, intraparietal sulcus, separating the superior parietal lobule from the inferior parietal lobule. And here we see posteriorly located parieto-occipital sulcus as a posterior boundary of the parietal lobe. And on the superlateral surface, as a summary, each parietal lobe lies posteriorly to each central sulcus, and posteriorly it is delineated by an imaginary line running from the point from which the parieto-occipital notch to the preoccipital notch, which is located approximately 5 cm anterior to the occipital pole. And its inferior boundary is the posterior ramus of the sylvian fissure and its imaginary posterior prolongation. So the lateral aspect is divided into 3 by postcentral sulcus and the intraparietal sulcus. And postcentral gyrus just lies between these central sulcus and the postcentral sulcus. While the intraparietal sulcus clearly delineates superiorly the superior parietal lobule, which is continuous medially with the precuneus, and inferiorly the parietal lobule. Postcentral gyrus just lies posteriorly and connected to precentral gyrus along with its superior and inferior extremities of the central sulcus. And it constitutes the posterior aspects of the paracentral lobule and the subcentral gyrus. And the postcentral gyrus is usually narrower than the precentral gyrus, and morphologically, both of them are distinctively obliquely disposed on the superlateral surface of the brain, just superiorly to the sylvian fissure, and their mid portions correspond approximately to the center of each cerebral hemisphere. And as a result of being oblique, superior portions related to the ventricular atrium, while inferior portions are related with the body of the lateral ventricle and just superior to the insula. And the portion of the subcentral gyrus that corresponds to the base of the postcentral gyrus consistently lies over the transverse gyrus of Heschel. And the postcentral sulcus delineates the postcentral gyrus posteriorly, and it's frequently interrupted due to connections between this gyrus and the posteriorly adjacent superior parietal lobule and the inferior parietal lobules. The inferior segment of the postcentral sulcus always ends inside a basal connection between the postcentral and the supramarginal gyri. When we come to the intraparietal sulcus, we are looking from lateral, but we are also looking from more posteriorly and superiorly. And here we see the intraparietal sulcus delineated by yellow dots. And this sulcus lies predominantly longitudinally and slightly ventrally concave along the mid portion. And we know that also intraparietal sulcus has lots of variation. It originates from around the midpoint of the postcentral sulcus, and it anteriorly usually continues with the inferior portion of the postcentral sulcus. And in general, the intraparietal sulcus runs almost parallel to the interhemispheric fissure. And posteriorly, it penetrates into the occipital lobe, and it continues as intraoccipital sulcus, or so-called transverse occipital sulcus. And here we see the depth of the intraparietal sulcus. As the postcentral sulcus, we know that there is lots of interdigitating sulcal branches. And also we have inferiorly and superiorly oriented vertical small branches. An inferiorly oriented vertical sulcal branch will be our intermediate sulcus of Jensen, which separates inferior parietal lobule into two. And then we have the transverse parietal sulcus of Brissot, which superiorly oriented sulcal branch, and it just divides the superior parietal lobule. So the superior parietal lobule is also a complex lobule lying between the intraparietal sulcus and the interhemispheric fissure, and it's anteriorly delineated by the superior aspect of postcentral sulcus. And it also has a quadrangular shape like pericuneus, and it's continuous with the pericuneus on the mesial surface. And its complex appearance is caused by a folding of the gyrus forming the two U-turns, and that can be called the anterior and posterior parts. It connects anteriorly with the postcentral gyrus and superiorly with the pericuneus. And posteriorly, it continues to the superior occipital gyrus via prominent parieto-occipital arcus that surrounds the parieto-occipital incisure. And occasionally, there is also a small sulcus emerging from the interhemispheric fissure over the superior parietal lobule. It locates just between the postcentral sulcus and the parieto-occipital sulcus, and this sulcus can be called as the superior parietal sulcus. When we come to the inferior parietal lobule, it is divided into two parts by the intermediate sulcus of Jensen, and they can be called the anterior lobule, called as like inferior lobule or supramarginal gyrus, or the circumflex gyrus. And posteriorly we have angular gyrus, or so-called middle lobule. And their irregular shape is formed by the terminations of three large sulci: the intraparietal sulcus, as we see here, the Sylvian sulcus, and the superior temporal sulcus. The bulge of supramarginal and of the angular gyri is responsible for the what we called is parietal tuberosity or parietal bossa. And the supramarginal lobule actually encircles the end of the posterior ramus of the Sylvian fissure, and its suprasylvian limb is continuous with the postcentral gyrus, while its infrasylvian limb is continuous with the superior temporal gyrus. And posteriorly and occasionally, it rounds the inferior extremity of the intermediate sulcus, which connects it to the angular gyrus. When we come to the angular gyrus, it lies just posterior to the inferior lobule and covers the incursion of the superior temporal sulcus into this region. And the most superior distal branch of the superior temporal sulcus has an ascending course and can either penetrate the supramarginal gyrus or coincidentally can be connected with the intermediate sulcus of Jensen, and sometimes intermediate sulcus of Jensen can be a branch of superior temporal sulcus as well. And posteriorly, the inferior parietal lobule merges with the occipital lobe, and its most inferior portion then becomes always anteriorly continuous with the middle temporal gyrus. And this is the medial surface of the cerebrum. Here we have a parietal lobe lying between the central lobe and the occipital lobe. And this is our another 3D model from Yeditepe laboratory. Now we are looking from the superior. And here we have the parieto-occipital sulcus and we have the central sulcus. And central sulcus ends into the central lobe. Here we have the paracentral lobule. And then here on the medial surface, we have another prominent sulcus that we called as the cingulate sulcus. And we have here the marginal branch of the cingulate sulcus, which forms the anterior boundary of the precynose. And each parietal lobe lies on the medial surface of each cerebral hemisphere. And the precynose gyrus just lies posteriorly to the paracentral lobule as a medial extension of superior parietal lobule along this perimedial border of the brain, and together with the medial aspect of the postcentral gyrus corresponds to medial portion of the parietal lobe. The precynose also has the quadrangular shape like the superior parietal lobule, and that's why it was also called by Dejeven like the quadrangular lobulofoveal. And it's delineated, as I said, delineated anteriorly, marginal branch of cingulate sulcus. And inferiorly, it's delineated by multiple Y-shaped sulcus segments that constitute the subparietal or suprasplanal sulcus. And the parieto-occipital sulcus that separates the precynose from cynose is a deep and wide sulcus when open and constitutes a deep fossa which harbors many sulci and gyri within it. And posterior arm of the precynose runs in continuity with the isthmus of the cingulate gyrus. And in a superior direction, the anterior gyrus of the precynose is also connected with the postcentral gyrus. And the middle and posterior arms of the precynose are connected with the superior parietal lobule along the superior medial border of the hemisphere. When we come to the functional areas of the parietal lobe, of course, we have to take a look at Brodmann map. So we have primary somatosensory area, which is located at the postcentral gyrus and at the whole postcentral gyrus actually. And we have the somatosensory association area, which is called as Brodmann area 5. And then we have Brodmann area 7 located within the superior parietal lobule. And inferior parietal lobule is represented with the Brodmann area 39 and 40. And along with area 22, they are called as Wernicke's area. What about the medial surface of the hemisphere according to Brodmann? So we have again primary somatosensory area, somatosensory association area, and the Brodmann area 7 just located within the precynose as like the superior parietal lobule. Von Economy and Koskinas actually define the area of map of human cortex in a more complex way, and they actually divide further the superior parietal lobule into three, like anterior, middle, and posterior portion of the superior parietal lobule. Inferior parietal lobule just resembles to Brodmann, and they also showed this sulcus intermedius of Jensen. Which separates the supramarginal gyrus and the angular gyrus. Medial surface is similar to Brodmann. And after that, Nivonius defined a new myeloarchitectonic area within the parietal lobe. And then they defined 30 different parietal myeloarchitectonic areas. And we know that the myelin content is the most in the primary motor and sensory areas. But interestingly, we have another high myelin content area, which is called as area 87. And it's called as the intraparietal dart cluster. And it's just shaded around the anterior part of the intraparietal sulcus. So during the approaches, we have to be careful about this area. And I also want to mention the nomenclature of the Punctinos. Here differently, he called postcentral sulcus inferior segment, but he defined also in ascending segment of the intraparietal sulcus, and also we have here the horizontal segment of intraparietal sulcus. And also they showed that it has 3 vertical inferiorly oriented smaller brines, and the first one will be the R sulcus intermedius of Jensen. What about the functions of the parietal lobe? So we have motor functions, sensory functions, language functions, reading functions, calculation functions, and the spatial attention functions within the parietal lobe. When we look closer to the motor functions, it prepares and redirects of movements and movement intentions. And as we know that corticospinal tract will be end at the somatosensory cortex of the postcentral gyrus. And the posterior parietal cortex deals with visuomotor transformations, which converts visual information into motor commands. And inferior parietal lobule works on grasping function. What about the sensor function? So we know that somatosensory information after getting into thalamus and going through the posterior limb of internal capsule, it also ends on the postcentral gyrus via these tracts, which are called the medial lemniscus sphenothalamic tract and trigeminothalamic tracts. And then we know that electrophysiologic studies show that stimulation of postcentral gyrus leads tingling and numbness sensation on the contralateral side. It's impossible not to mention language when we talk about the parietal lobe. So dominant inferior parietal cortex deals with language comprehension, and their damage will lead to Wernicke's aphasia. And dominant supramarginal gyrus and arcuate fasciculus, if there is a damage, it leads to conduction aphasia. Non-dominant perisylvian parietal cortex deals with prosody of speech, so their damage will be sensory aprosodia of the speech. When we look for the reading, alexia with agraphia results due to dominant angular gyrus damage. And dominant angular gyrus has another function, and it's called as calculation center as well. And also we need to mention the Gertzmann syndrome, and it's caused by damage to the inferior parietal lobule. What are the findings of the Gertzmann syndrome? Agraphia with alexia, disorientation for right and left, finger agnosia, and acalculia. What about the spatial attention function? Non-dominant parietal lobe deals with spatial orientation, which are the area 5 and 7. And their lesions leads to difficulty with spatial orientation to the contralateral side, and as well neglect of half of the body and other objects. And parietal association cortex deals with tasks that require mental manipulation of objects. And I'd like to briefly discuss recent publications on the functional areas of parietal lobe and the anatomy of white matter. And as we know that the superior parietal lobule is an important region implicated in a variety of tasks. What are those? Like language processing, writing, working memory, attention, visuospatial, and visuomotor integration. And in this study, the corresponding cerebral networks related to these functions deals with white matter tracts are described in the study. And the connections between the superior parietal lobule found with the other lobules, and it has connections almost with all other lobes like frontal lobe, limbic lobe, temporal lobe, occipital lobe, and the other parts of the parietal lobe as well. And what are those tracts we deal with when we talk about the superior parietal lobule? We have the inferior front occipital fascicle, superior longitudinal fascicle, cingulum fibers, and middle longitudinal fascicles, and extreme capsule, and of course we have the superficial white matter, which is also called as U fibers. And this is another study dealing with the angular gyrus. And in this study, they divide the angular gyrus into two parts by their position to the superior temporal sulcus. And they found that the tracts related with the superior angular gyrus and inferior angular gyrus is differ from each other. So they summarize the tracts related with those regions. So arcuate fascicle, front occipital fascicle, and the tapetum will be both in the superior and inferior angular gyrus, while we only have superior longitudinal fasciculus and middle longitudinal fasciculus in the superior angular gyrus. So Gertzmann syndrome and spatial hemineglect will be observed in the isolated damage of the superior angular gyrus, while verbal anosmia, quadrantonopia, and visual defects will occur in isolated damage of inferior angular gyrus because they have the anterior commissural fibers and the optic radiation fibers. This is another study about the fiber connections of the supplementary motor area, and they divide supplementary motor area into peri-supplementary motor area and supplementary motor area proper. So they found that their functions are differ from each other. So peri-supplementary motor area mostly deals with somatosensory organization, cognitive and non-motor tasks, while SMA proper deals with activation, control, and generation of movement and somatotopic tasks. Because SMA proper have corticospinal tract, but peri-SMA has no corticospinal tract, and it actually has claustrocortical fibers connecting between the claustrum and the anterior edge of the peri-SMA area. And this is another electrophysiologic study about the parietal lobe. So they found that posterior reading network overlaps with the language network. So the inferior parietal lobule, underlying arcuate fasciculus, occipitotemporal visual form area, and underlying inferior longitudinal fasciculus, they work with each other for reading and language network. And then also precuneus functions was not clearly defined, and this study had the aim to define the function of the central precuneus. So they did the study, and their goal was to test the hypothesis that the central precuneus is preferentially involved in as executive function. And they made impaired trail making test for 35 patients with focal brain lesions involving the precuneus. And it was clearly concluded that the precuneus area has critical role in executive function. Lastly, I will mention the blood supply of the parietal lobe. So we have three main branches as MCA, ACA, and the PCA. What about the MCA cortical branches? So we have central artery giving supply to the inferior half of the postcentral gyrus, and we have anterior parietal artery supplying the superior part of the postcentral gyrus and anterior part of the posterior parietal lobule. And we have the posterior parietal artery feeding the posterior part of the posterior parietal lobe and supramarginal gyrus as well. And lastly, we have the angular artery supplying both inferior parietal lobule. When we come to the ACA cortical branches, we have paracentral artery, which supplies the premotor, motor, and somatic sensory areas, and it is represented as the terminal portion of the ACA. And we have precuneal artery and so-called parietal arteries, which supply the precuneus area. When we come to the parieto-occipital artery, it's a branch of the posterior cerebral artery, and it frequently shows collateral supply networks to the precuneus and cuneus via anastomosis with the precuneal artery, here we see, and the calcarine artery. And when we open the parieto-occipital sulcus, we see that it lies here, and as we said before, it's very wide sulcus actually, and it has the precuneal branch as well. And those were my references when I was preparing this slideshow. And similar to what Vasily Kandinsky said, the principle only by means of a detailed anatomical study can the surgery of art lead to a comprehensive success also applies to our field. And this is the Yeditepe University Microneurosurgery Laboratory. I just want to show a brief video. So we have photo documentation station, we have workstation. We have 4 microscopes. Here we see Professor Abuzar Güngör, who is the director of the laboratory. This is the 3D model of our laboratory. Thank you for listening.
Thank you very much, Professor Ayso Kabaki, for this nice presentation and thorough information. Dr. Mujahid, any word?
Dr. Ahmed. Thank you, Dr. Aysu Kabaki from Ankara Hospital in Turkey for this nice presentation. Discussion later on or now, Dr. Ahmed or Dr. Ismail is ready?
We'll see if there is any questions. I think the presentation was clear and very thorough. We'll see if anyone of the audience have any question for Professor Ayso Kabaki.
You have questions in
comments?
chat or not? No. You haven't.
We don't see any question here, but is there anyone who want to have any question or have any comments for Professor? As always in anatomy, there is no much questions, and the presentation was very, very informative and very thorough. So I don't think there is any unclear points.
It was very clear.
Thank you.
Thank you. I can stop sharing if you like.
Okay, thank you very much.
Thank you.
Dr. Ismail, are you in? Let's see if Dr. Ismail is ready, so we can start with him. So, Professor Ayso Kabaki, you have a neurosurgical lab at your institute?
No, unfortunately, we don't have.
Thank you, Dr.
But we are trying to have one. But
Aysu.
Yes.
Dr. Ahmed want to participate in their labs, huh?
Yes, we want to ask about the labs, if they have a neurosurgical lab, and to ask about their experience in it. It's very
for
good.
Our residents and staff, members.
Okay.
The lab that you
I think it is ready there in Ankara. Yes, at the end of lecture.
Professor Ayso,
I'm sorry?
the lab that you show in the end of your presentation, it was in your institute or in another institute?
No, it's another institute. It's located at Istanbul.
In Istanbul.
Yeditepe University Microneurosurgery Laboratory. Yeah, I've been there for 6 months as a fellow. But unfortunately, we don't have any laboratory in our institution.
I think,
But
as you
Yeditepe
mentioned,
University Microneurosurgery Laboratory has lots of opportunities. And they welcome everyone who want to visit. And it's open actually 24 hours.
It's good. That's nice.
Nice.
Good, yes.
Dr. Aysu can coordinate for our members.
Yes.
I think that you mentioned that Dr. Abuzar Güngör is the head of that laboratory, yes?
Yes, he is the director of the laboratory, and the founder of the laboratory is the Professor Uğur Ture.
So we can contact him and see if we can do collaboration and send some of the residents in our institution to train there.
Yeah, sure. I can contact with Professor Abuzar and then we can talk. Sure.
إن شاء الله. Thank you. دكتور إسماعيل, are you ready? دكتور إسماعيل.
دكتور إسماعيل.
Hello everyone.
ربنا يديها.
I have problem today with my laptop to introduce to the lecture, so I will try to do it from the phone. Inshallah, it will.
Our next presentation
إن شاء الله.
will be with Dr. Ismail. Dr. Mujahid, you can present Dr. Ismail and his lecture.
Embryology on development of the brain by Dr. Ismail. Regarding embryology and development of brain, yeah? Dr.
Yes.
Ismail is a consultant neurosurgeon, is assistant prof in 21 September University. And he will present his lecture now. Are you ready, Dr. Ismail? Inshallah.
Just a minute, I have problem with the connection, so I will try to.
No, that's it. It started. Good.
Okay, it's clear.
We see white
Sharing.
background. We don't see anything else. Yes.
Okay, sorry. The PowerPoints appeared with you.
We only see the white background. We don't see the presentation.
So I will start to talk about the embryological development of the central nervous system.
دكتور إسماعيل.
ها؟
احنا شايفين بس خلفية بيضاء, مش شايفين أي حاجة ثانية.
Maybe the net is loading. Still loading.
Maybe you can exit screen sharing and do it again.
I will do it again.
So we see white background. We don't see the presentation. If you can move or to the next slide, maybe.
Is a technical problem.
Just a minute.
Branch out a bigger view.
Share whiteboard classic. Just a minute.
I think you didn't share the presentation. You shared let's see. Yeah. Oh yes, I think
okay
now
now?
it's good. Now I see it. Yes, it's good.
It's okay.
Now it's okay.
Yeah,
Now
that's okay.
okay.
Start, please. It's okay.
Sorry for this problem. So I will talk about the embryological development of the central nervous system. First of all, the first stage of this development is usually by the junction of the sperm and the ovum to form a fertilized oocyte. After that, this oocyte, the mature oocyte or the fertilized oocyte, is divided to two cells. the two cells undergo multiple division to form about 16 cells, which is called the morella. This morella undergo more differentiation to form a fluid inside this group of cells. It's called the blastocyst. So the blastocyst consists of three components. The first one is the fluid and the two groups of cells. This group of cells is the inner cells. It's called the embryoblast, which form the embryo and the fetus later on. And the outer cells, it's called the trophoblast, which will form the placenta and which will penetrate through the endometrium of the uterus. So as we talked before, the embryoblast, which form the embryo and the fetus, and this outer layer is the trophoblast, which will form later on the placenta and penetrate the uterus. So the embryoblast at the third week of pregnancy will undergo more differentiation to two types of cell. So the inner cells of the blastocyst will undergo more differentiation to two types of cells: the epiblast and the hypoblast, as we saw here in this diagram. At this stage, the pregnancy sac is called the bilaminar embryonic disc. So this diagram also shows the bilaminar embryonic disc. So if we do a cut section at the coronal direction, we will see the amniotic sac and the umbilical vesicle. Between them is the bilaminar embryonic disc, which is formed by two types of cell, an epiblast and the hypoblast. So the epiblast, which in the front of the or in the direction of the amniotic fluid, this is the surface of the epiblast. This is the amniotic cavity, and the epiblast in the direction of the amniotic cavity. This is the cut section or axial view of the amniotic of the epiblast. The epiblast has many landmarks, anatomical landmarks, like the cloacal membrane and the oropharyngeal membrane. The oropharyngeal membrane is formed in the cranial part of the epiblast, and the cloacal membrane in the caudal part of the epiblast. The oropharyngeal membrane will form later on the mouth, and the cloacal membrane will form later on the anus. Just cranial to the cloacal membrane will form a groove at the epiblast, is called the primitive groove or the primitive streak. So as we talk, there is a groove just cranial to the cloacal membrane. It's called the primitive streak. It appears at the midline of the epiblast layer. At the cranial part of this primitive groove or primitive streak, there is what's called primitive node, just dilatation of this groove. It's called primitive node. At the center of this primitive node is the primitive pit. It's important clinically and at the embryological development, as we will talk later on. After the development of the primitive streak and primitive node and primitive bed, there is a process which is very important at the development of the embryo, is called the gastrulation. The gastrulation is the process through which the cells of the epiblast layer break off and migrate toward the primitive bed to form three layers. So the cells of the epiblast will differentiate and undergo more division and growth and migrate through the primitive bit, as we told before, at the cranial part of the primitive groove. Then migrate to the underlying layers, as we saw here in the coronal view. It migrates down to the and replace the hypoblast layer to form the endometrium endoderm, and to the space between the epiblast and hypoblast to form the mesoderm. And it replaced the cells of the epiblast to form the ectoderm. So at this stage, the three important and the three main layers of the embryo is formed at the process of gastrulation. At this stage of gastrulation, after it's finished and mature, the embryonic sac is called the trilaminar embryonic sac or disc. So as we talked, the endoderm is formed by the epiblast cells, which growth and migrate through the primitive bit to replace the hypoblast cells, as we saw down, to form the endoderm. While the mesoderm is formed by the epiblast cells, which also migrate through the primitive bit to the space between the endoderm and the ectoderm. While the ectoderm is the outer layer, is formed by the differentiated cells of the epiblast, which replace the cells of the epiblast, and it remains at its position. So at the end of this process of gastrulation, the bilaminar embryonic disc will be called the trilaminar embryonic disc, as we saw in this both diagram. The left one is called the bilaminar, and the right is called the trilaminar. After that, it's the process of development of the central nervous system. So the three layers of the embryo is formed: the endoderm and ectoderm and the mesoderm. And now a process is called neurulation, which the first steps or first process of formation of the central nervous system. The neurulation starts by formation of the notochord. The notochord is a differentiated cells of the mesoderm at the midline at the mesoderm layer, which is called the notochord. As we saw in this diagram, at the left one is the axial view, and the right side is the coronal view. The coronal view shows this red dot is the notochord at the mesoderm at the midline between the endoderm and the ectoderm. This notochord is very important because it secretes growth factors which stimulate the ectoderm to differentiate the above ectoderm to differentiate to neuroectoderm. And it stimulates also the growth to make this layer over the notochord is thick. So the function of the notochord is to secrete growth factors to make the ectoderm to differentiate and growth more to be more thick and differentiated from ectodermal cells to neuroectodermal cells, and called the neural plate. This neural plate over the notochord start to develop more and more to form a fold, and it will grow up and medially. This neural plate will grow more and make the neural folds, which grow up and medially to form a groove at the central part called the neural groove, and laterally is the neural fold. Between the lateral to the neural folds, a special type of cells is called the neural crest, which is by the green color. So the neural folds move more and more toward each other to fuse finally at the midline. Usually, the fusion started at the middle part of the neural tube. So the plate is grew more, and to make the folds is meet at the midline to make neural tube. This neural tube is formed early or closed early at the midline at the middle part of this tube, and then migrate proximally and distally to close the whole to close the whole neural tube. Also, as we see in this diagram, the green color cells is the neural crest, as we will talk later. So fusion of this neural folds occur at the middle of the neural plate, then cranially at the 25th day, it will close the anterior neuropore, and distally and closed at the 28th day at the distal part, which is called the caudal or the posterior neuropore. So the cranial neuropore is closed earlier than the caudal. During closure of this tube, after it's closed, it contains at its center a cavity which is filled with fluid. This fluid is formed later on the cavities of the CSF in the form of the ventricles and central spinal canal. So the central spinal canal and the ventricles is formed at the cavity, which is formed by the closure of the neural tube. So till this step, we finished the neuralization process. The neuralization process is matured and the neural tube is closed. But if there is any defect at this process, at the previous steps of neuralization, it will form what's called group of congenital anomalies, the neuralization defects anomaly. The neuralization defect anomaly is divided to many types according to the site of the defect which is not closed. So if the whole tube is failed to fuse and closed, it will form what's called cranioreschisis, which is failure of formation of all the brain and spinal cord at all. And this is not compatible with life and usually stillbirth and death at the embryo life. If the anterior neural failed to close, it will form what's called the anencephaly, with failure of the formation of the brain and part of the meninges and skull bone and part of the scalp. If the failure of closure at the distal part or the caudal part, it will lead to what's called the spinal dysarthrism or open spina bifida and closed spina bifida. The anencephaly and anencephaly also were parts of the failure of closure of the neural tube, which, as we said, all of these groups of congenital anomaly is called the neuralization defects anomalies. After the neuralization and closure of the neural tube, it usually separated from the overlying ectoderm. As we see here in this diagram, after closure, it's go inside and closed by the overlying ectoderm and the neural crest cells. So after this process, we will go to another steps or another process of embryological development, which is called the post-neurulation development. The post-neurulation development usually started by the growth of the cranial part of the neural tube and to form three vesicles, which is called the primary brain vesicles. This primary brain vesicles is the borencephalon, mesencephalon, and rhombencephalon, which will form later on the brain, the cerebrum and cerebellum and the brain stem. This primary vesicles will undergo more maturation and differentiation to form the secondary, the five secondary brain vesicles. So the borencephalon, which one of the most cranial part of the primary vesicles, will differentiate to the telencephalon and diencephalon, while the mesencephalon will stay the same as the mesencephalon, will not divide it. The rhombencephalon, which is the most caudal part of the primary brain vesicles, will differentiate to the metencephalon and myelencephalon. So the five secondary vesicles will form the brain and brainstem and the cerebellum by these five vesicles. As we see also in this diagram, the primary vesicles will differentiate it to the secondary vesicles. Also, this diagram shows a coronal view and lateral view of the primary vesicles, which will differentiate to the secondary vesicles. The primary vesicles, of course, three, which developed at the fourth week of pregnancy. The secondary brain vesicles is differentiated at the fifth week of pregnancy, and will later on make a derivative of the central nervous system, as we will talk later on. So the derivative of the secondary vesicles, it's according to the secondary brain vesicles. So the telencephalon will form the cerebral hemispheres, caudate, putamen, amygdala, colostrum, lamina terminalis, and olfactory bulbs and hippocampus. While the diencephalon will form the thalamus, epithalamus, and subthalamus, and the hypothalamus. And the neurohypophysis, pineal gland, globus pallidus, mammillary bodies, and optic chiasm and nerves, retina, epithelium of the iris, and ciliary body. While the derivatives of the mesencephalon is the midbrain. The derivative of the metencephalon will form later on the bones and the cerebellum. The myelencephalon will form the medulla oblongata. And the caudal part of the neural tube after the myelencephalon will form the spinal cord. This table summarizes the primary and secondary vesicles and its derivatives, and also the cranial nerves and ventricle. For example, the telencephalon will contain inside it the lateral ventricle, which is previously the central cavity of the neural tube. The diencephalon will contain within it is the third ventricle. The mesencephalon will contain the cerebral aqueduct. Metencephalon will contain the proximal part of the fourth ventricle, and the myelencephalon will contain the distal part of the myelencephalon. While the neural crest, as we talked before, which surround the neural tube, and as we talked before, is a specialized type of the neural tube cells, which separated from it and become surrounding, will form the cranial and spinal and the autonomic ganglion. Also, it contains the it will form later on the pia and arachnoid. Also, it will form later on the Schwann cells, melanocytes, and carotid body. Also, it will form later on the suprarenal medulla and the ganglion cell layer of the retina. After that, the secondary brain vesicles also already developed and start to form the derivatives of the secondary brain structures. The next process is the more maturation of the derivatives and the structures of the central nervous system. It's formed and it's done by the formation of the neural cells and the neurons and its migration. So the neural tube is lined with neuroepithelial cells. This neural tube is contained inside it the neural canal. This neural canal is lined with cells is called the neuroepithelial cells. As we see here in this diagram, this is the left one of these cells is the neuroepithelial cells. These neuroepithelial cells which surround the neural canal will differentiate to an important type of neural cells and a very important cell in the development of the central nervous system called the radial glial cells. These radial glial cells will differentiate to types of cells, as we will talk later on. Also, this diagram shows the neuroepithelial cells and its differentiation to the radial glial cells. So the cells with the yellow color is extended from the wall of the ventricle to the outer membrane or the basement membrane of the neural tube, with its processes projected from the wall of the canal to the basement membrane. These radial glial cells will be divided into many types of cells. First, it will copy itself to more growth and multiplicate the number of the cells. So it will form, it will divide to form the more new radial glial cells. Another types of cells is formed by the radial glial cells is the intermediate progenitor or called neuron progenitor. So these radial glial cells will divide also to one of the important types of the neural maturation is called the intermediate progenitor or the neuron progenitor. This neuron progenitor or intermediate progenitor, as we see in this diagram, will undergo more differentiation to which is called bipolar cells, bipolar neural cells. These bipolar neural cells along the process of the radial glial cells, which we will see here, and it will migrate along the process of the radial glial cells from the surrounding the canal to the outside in the direction of the basement membrane. So this is the migration of the neurons from the paraventricular and paraspinal canal to the cortex. So these cells is formed by the radial glial cells differentiate to intermediate progenitor, and this intermediate progenitor will be differentiated to and specialized to bipolar cells. These bipolar cells is migrate along the process of the radial glial cells to the basement membrane at the cortex. Also, this diagram shows the neural progenitor at the base of the radial glial cells, which is made by the red color, and will be specialized and differentiated to the bipolar cells, which is above it at the level of the cells, and then migrate along the process of the radial glial cells in direction of the cortex to reach to the final position of these neurons at the cortex. Also, the radial glial cells, one of its division is the macroglia. Also, these radial glial cells will differentiate to another type of cells. It's called the macroglia. This macroglia is the astrocytes or oligodendrocytes. This cells is the support of the neurons and give the nutrition and maintenance of the blood-brain barrier and myelination. So, to make revision about this radial glial cells, it divides into 3 types of cells. It make multiplication for itself to make more cells of radial glial cells. Also, it divides to the neural progenitor, or called intermediate progenitor, which will form later on the neurons. Also, it's divided to form the macroglia in form of astrocytes and oligodendrocytes. So, after this radial glial cells finish to make multiplication and migration of neurons and make all the macroglia, its function is finished. And the process which extend from the neural tube to the basement membrane outside is regressed, and the cell itself is located and located at the paraventricular area and make the lining of the ventricle and the central spinal canal in form of the ependymal cells. So this radial glial cells will form finally the ependymal cells at the lining of the ventricle and the central spinal canal. Okay. During this process, the previous process, which we will talk previously, the maturation, the post-neurulation, maturation, and the maturation and the migration. There is some defects occur during this process of the maturation and migration. This group of congenital anomalies is called the post-neurulation defects, which is also known as closed lesion or skin-covered lesion, also known as migration defects. These migration defects can be divided to cranial and spinal. The cranial in the form of microcephaly, hydrancephaly, holoprosencephaly, lysencephaly, schizencephaly, and macroencephaly. Heterotopia and cortical dysplasia also is types of the post-neurulation defects. The spinal post-neurulation defects in form of the split cord malformation and the hydromyelia and syringomyelia. So this one type of the post-neurulation defect is the hydrancephaly, which absence of the supratentorial part of the cerebrum and part of the diencephalon, and replaced by CSF. So I will go rapidly about this because the time is not enough. Also, another type of the post-neurulation defect is the holoprosencephaly, which is failure of the telencephalic vesicles to cleave into 2 cerebral hemispheres. There are many types of the holoprosencephaly in the form of allobar, semilobar, and lobar. Also, one of the post-neurulation defects is the lyssencephaly, which is maldevelopment of the cerebral convolutions, mostly due to arrest cortical development. There are also types of lyssencephaly, agyria, brachygyria, and polymicrogyria. Also, another type of the post-neurulation defects is the schizencephaly, which is cleft that communicate with the ventricle, the cleft lined with cortical gray matter. Usually, it's two types, open-lipped or closed-lipped. This is the open-lipped schizencephaly, which communicate between the ventricle and the cortex. Another one is the closed schizencephaly, which open from the ventricle to the parenchyma. Differentiate from the borencephaly by the lining cells of the cyst or the encephalomalacic part of the brain. So if it's gray matter, that means it's schizencephaly. While if it's white matter, it's mostly due to borencephaly. Another type of the post-neurulation defect is the heterotopia, which is abnormal foci of non-enhancing gray matter, which may be located anywhere from the subcortical white matter to most commonly the subependymal lining of the ventricle. So during migration, as we talked before, during migration of the neurons, there is a defect which will arrest the neurons to make it in abnormal position. It results from arrest radial migration, presentation usually seizure. Okay. Another type of the post-neurulation defect is the cortical dysplasia, which is cleft that does not communicate with the ventricles. It's opened from the cortex to some deep of the brain tissue, as we see here in the MRI and in the gross anatomy. Usually is presented with seizures. Also, another type of the post-neurulation defect is the microcephaly. Also, another type is the macroencephaly. The spinal post-neurulation defects in the form of the split cord malformation, which is two types, diastomatomelia or diplomylia, which is type 1 and type 2. In split cord malformation, type 1 is called diastomatomelia, which is two cord in two separated dura, and there is a separate between the two cord is the cartilaginous or bony spur, separating both the spinal cord, while the type 2 is two hemichord in the same dura. This is a type 2 within a single dura tube, separated by non-rigid fibrous median septum. It's associated usually with tethered cord. The management is removal of bony or cartilaginous septum, detethering reconstruction of dura. Also, another type of the spinal post-neurulation defect is hydromyelia and syringomyelia. Thank you for your attention.
Thank you very much, Dr. Ismail, for this presentation. I think Dr. Mujahid is still here. Dr. Mujahid.
Dr. Ahmed.
Yes.
Finished?
If you have any, I think Dr. Ismail already finished.
Yeah, thank you, Dr. Ismail, for this nice presentation. And for the
Stop your screen
participants
sharing, Dr. Ismail.
Any question, any discussion?
Dr. Ismail, you can stop your screen sharing. I will see the chat if there's any question or any comments for Dr. Ismail. I don't see here any questions.
Any
If
question?
anyone has a question or a comment for Dr. Ismail, please go ahead. I think there is
no questions. I want to thank
Dr.
Dr. Ahmed Jaradi for this nice preparations and continuous medications, continuous education lectures of the Yemeni Society.
Thank you, Doctor, for your nice work. This all by your support.
Dr. Aiso and Dr. Ismail for the two nice presentations today.
Thank you,
Dr.
bro.
Ahmed.
Thank you, bro. Thank you for all of this.
So I think there is no more questions. So I think we can conclude our third session of the comprehensive neuroanatomy educational course. And thank you, Professor Dr. Aiso Kabaki and Dr. Ismail Mansour for this amazing presentations and this informative lectures. And I think we can conclude today's sessions, and we are waiting for you next Friday, inshallah, with more presentation and more lectures, inshallah. So thank you, everyone.
Inshallah. Thank you, Dr. Ahmed. Thank you, Dr. Ismail. Thank you, Dr. Aiso.
Thank you, bro.
See you next Friday, inshallah.
See you.
Bye.
Thank you, Doctor.